Today's talk is about replacement fluids therapy. The gastrointestinal tract is potentially a source of considerable water loss. GI water loss are accompanied by electrolytes, so they may cause disturbance in intravascular volume and electrolyte concentration. Because of the high bicarbonate concentration in stool, children with diarrhea usually have metabolic acidosis, which might be accentuated if volume depletion causes hypoperfusion and a concurrent lactic acidosis. Emesis or losses from NG tube can cause a metabolic alkalosis. The child should receive an appropriate maintenance fluid that does not consider the GI losses. The losses should then be replaced after they occur with use of solution with similar electrolyte concentration as the GI fluid. The losses are usually replaced every 1 to 6 hours, depending on the rate of loss, with very rapid losses being replaced more frequently. When we see replacement fluids for diarrhea, the volume of stool should be measured and an equal volume of replacement solution should be given. Average composition of diarrheas regarding electrolytes: sodium around 55 milliequivalent per liter, potassium around 25, and bicarbonate around 50 milliequivalent per liter. The solution for replacement of ongoing losses in diarrhea is half D5 and half normal saline with 30 milliequivalent per liter of sodium bicarbonate and 20 milliequivalent per liter of KCl. Replacement should be done in ml in ml every 1 to 6 hours. The other is replacement fluid for Emesis or nasogastric losses. Loss of gastric fluid through MS or NG sanctions is likely to cause diarrhea, in that most patients with either condition have impaired oral intake of fluids. The average composition of gastric fluid include sodium around 60 milliequivalent per liter, potassium 10, chloride around 90 milliequivalent per liter. The solution for replacement of Emesis and the NG tube losses are normal saline with KCl. Normal saline plus 10 milliequivalent per liter of KCl. The replacement of output should be done ml in ml every 1 to 6 hours. The other is replacement fluid for polyuria. Urine output is normally the largest cause of water loss. Diseases such as post-obstructive diuresis, the polyuric phase of acute tubular necrosis, diabetes mellitus, diabetes insipidus increases urine production. The electrolyte losses in patients with polyuria are variable. In diabetes insipidus, for example, the urine electrolyte concentration is usually low, whereas children with diseases such as juvenile nephronoptosis and obstructive uropathy usually have increased loss of both water and sodium. Polyuria, the replacement of insensible fluid loss with half D5 and half NS with or without KCl. We should have to measure urine electrolytes and replace urine output ml in ml with solution based on measured urine electrolytes. Surgical drains and chest tubes can produce measurable fluid output. These fluid losses should be replaced when they are significant. Third space losses, which manifest as edema and ascites, are caused by shift of fluid from the intravascular space into the interstitial space. Although these losses cannot be quantified easily, third space losses can be large and they might lead to intravascular volume depletion despite the patient's weight gain. Replacement of third space fluid is empirical, but should be anticipated in patients who are at risk, such as children who have burns or abdominal injury. Third space losses and the chest tube outputs are isotonic, so they usually require replacement with isotonic fluid such as NS or Ringer lactate. Adjustment in the amount of replacement fluid for third space losses are based on continuing assessment of the patient's intravascular volume status. Protein losses from chest tube drainage can be significant, occasionally necessitating the replacement or administration of 5% albumin, which can be used as a replacement solution. Thank you for watching and subscribing to the channel.